Okay, we have to welcome to the webinar. Please be aware that there was a major incident with Microsoft Teams yesterday when everything stopped working, and we have heard reports that there were still some glitches this morning. So if something goes terribly wrong, we hope not, but it could happen, and it's not in our control. It's Microsoft. It can happen even to giants like them. We will send you the slides, yes, and the dashboard right after this very short session, so don't worry about it. And yeah, let's get started really. Sorry, I have to share. I forgot to share. Lacey, let me know if it's not visible.
No, you're perfect, Anna.
Okay, lovely. Thank you very much. Okay, so most of you know me, Anna, Senior Primary Care Facilitator for CEG, and I'm sure you all know Keith Prescott, our CEG manager. So we'll be both presenting in this session. It's a very short session, and because the objectives are just three: remind you of the context of the structured medication review desk, present our new NEL dashboard to support this desk, and collect feedback from you on how to develop it to best fit your needs. Before I proceed, I would like to thank Maninder in particular from the TNW, as it is called now, CCG, who was instrumental in putting all heads together from across NEL when it came to producing searches and templates and instigating the creation of this dashboard. So thanks, Maninda. Just a very quick reminder of the timeline about this SMR desk. The first we heard about it was in December 2019, when a first draft was published together with the rest of the new PCN desks, and it was very unpopular because the amount of work implied for general practice was massive. There was such an outcry that the specification was amended in February 2020, and one of the critical changes was that the volume of work required would be determined by the clinical pharmacist capacity, and also the start was delayed to the 1st of October 2020. So the final revised spec was published in September, ready for deployment in October, which is when the scheme went live. And now on the 31st of March of 2021, the spec for the year ahead has been published with really minor amendments. It's more, I would say that it's almost like cosmetic rather than the spirit of it. So the main component of SMR patient eligibility is through proactive action on parts of the networks, and it comprises 5 groups. Is about reviewing care homes residents, then people on what they call complex and problematic polypharmacy. This is easier said than done. I mean, if we just interpret it as 10 or more medications, that's fine, but the complex and problematic is a little bit more difficult, and you probably know more than me about this. The next category is medicines commonly associated with medication errors, and the guidance this year is still based on the same as last year, which is a document that was published in August 2019. Probably the only difference is that the specification this year also makes explicit mention of valproate on women of childbearing age, so we have to be mindful of that. The next group is patients with severe frailty, and the last category is medications that are potentially addictive, with a specific mention of opioids and all these other categories that I find very difficult to pronounce. And then there is reactive eligibility. So so one thing is looking for patients who would benefit because you know that they would proactively because of whatever their conditions or current medication. But then is the reactive eligibility, which is when there is a crisis or an incident, and a crisis or an incident can be something, for example, like an emergency admission. Personal concern, and this means concern from a patient or their carers. If their carers, for example, think that a certain medication is not agreeing with them or causing them difficulties, or their regime is not working, basically. It's also professional referral. So basically, any it could be a care home worker or some other clinical worker who thinks that the patient would benefit from a proper structured medication review, and also when there is a request for dosage assistance. Just a very quick reminder of the contractual requirements for this test, which are proactive identification, which we already addressed, deliver certain volume determined by the capacity that you've got in terms of how many clinical pharmacists you have. So it's not going to be the same in different networks. You have to do invitations for the patients that explain the benefits, and this is just in line with invitations for everything, like starting with cough, that very clearly says that you can't just say come here for a review. You have to explain why, how the patient is going to benefit from this particular review. And the delivery has to be by adequately trained clinicians. So not, for example, you couldn't have an admin person doing this kind of review, just being extreme. You have to clearly record all the SMRs within GP80 systems. Sorry, this was not very easy at the beginning because the SMR actual code came out a little bit late in the year, but it's available now, and obviously available in our template. And collaboration with wider medicines optimization programs is a requirement as well, and that means that the networks have to engage with the CCGs and the medicine optimization teams in terms of optimization of antimicrobial prescribing, medicines that cause dependency, low carb alternatives for inhalers, and trying to reduce the prescribing of medicines of low priority, for example. And the last contractual requirement is working with community pharmacies to promote the new medicine service, where they support patients with asthma, COPD, type 2 diabetes, hypertension, or blood thinners. So from CEG, as we said, we worked in collaboration with the medicines optimization team, and we developed a very comprehensive template, which was tested by clinical pharmacists, and which we are always happy to receive feedback on, particularly now that we're in a new financial year, on patient identification searches. Again, these were there was wide consultation on them, but we would be very happy to review the feedback at this time in the year. Is a perfect time to do that. Just a screenshot to remind you what the template looks like. It's very, very comprehensive, and also the searches that you might be familiar with. And without further ado, I will let Keith demonstrate the actual dashboard, which is why we're here. What we're here for today.
Right. Thanks, Anna. Before we start, you might want to make your MS Teams screens full size in order to get the detail, because there's an awful lot of detail in the dashboard I'm about to show you. Just going to share screen. I'll just kill my image. Okay, can everyone see this okay?
Yes.
Now on screen, yeah, good.
Yes.
So there's quite a bit of functionality in this tool, so I'm going to just give you a kind of an overview of how that functionality works. There's 3 tabs along the bottom here: full report, network trend, and the PCN DES business rules, which is actually the information that will be sent up via CQRS. So if you actually want to look at the numbers without having to go into the searches, this will give you a quick overview. And another thing to remember, when you open these more sophisticated dashboards, you will need to enable content and probably will need to save the file, because although it doesn't have any macros like some of our older ones do, it does have quite a bit of functionality. So taking it from here, we've got what you've got is this is your full report. So the first thing your probably eyes are drawn to is the all the different groups A, B, C, D, and E, which Anna's already described. Lives in nursing home, 10 or more medication courses, etc. You see a nice breakdown across here of the NEL networks and boroughs. Sorry, it's not the networks, it's just the boroughs, and you can actually see within the boroughs who's doing better at certain SMR recording in the different groups. So here, City and Hackney are over 30% for SMRs on patients living in care homes. It's probably worth bearing in mind, though, that different localities will be at different stages of progress, depending on whether you've got local schemes or when you started promoting this particular work stream. So it's not meant to be overly competitive, but it does give you an idea of where you stand across NEL. Now you've got a date here. The date function at the moment's only got 2 dates in, so it's not really much I can demonstrate on that, because this is only the second point of data. But it will be accumulative, so effectively you only ever really want to see where the most recent date form, and you'll get your trend line. So as you can see, there is a couple of date points in there, and hopefully you'll see all these trend lines going up in terms of how well you're doing in your boroughs. If you particularly want to look at your borough, so let's have a look at let's click on Tower Hamlet. No, let's click on Newham. Don't always get so immediately you get broke down by Newham. You can see the immediate the levels of recording, the levels of achievement for SMR by the different groups in Newham. There's a nice little feature in this view here. It's difficult to see, but if you look, you've got expand and you've got collapse. So I think if I just do that, it will then give me a breakdown of the individual networks within Newham. If I wanted to go further, I can click on it, and then it actually goes into the practices. So that's too much data, really, to be honest, on this one. You probably can't really make them out, but that's quite a handy feature if you just want to see how well your network's doing against other networks, particular aspects of SMR undertakings. Take it back. If you actually want to compare, I think you can compare your borough with another borough. So if we wanted to say, let's have a look at Newham versus Havering. Let's just see if this works. There we go. You can select 2 boroughs next to each other, or 3 for that matter. You have to use the shift key. So you have to be a little bit familiar with some of the functionality in Excel to really get the most out of this. But once you've used it a few times, you'll find it quite easy to navigate around. And up here, you'll see the filter. So when you're tired of looking at that particular view, just click. If you see the little red cross, you've got filters on. Just click that off and it goes back. Select locality, and we're back to normal again. If you want to look at particular networks within that, you can also do it from here. Or equally, you've got a collapsible function here, so we can just open up one of these. Just click on these tiny little crosses. It does touch your eyes a bit if your eyes are getting a bit old like mine are, but then you can get the breakdown by the networks and the individual practices if you want to. Okay, so that's page 1. Network trends. This is more useful with it if you're a clinical director or a network manager. This is probably quite a useful view in the sense of seeing how well you're doing within the network. So at the moment it's set to Tower Hamlets still, and you can actually see these are the size, the volume, because Anna mentioned earlier about the importance of the volume of SMR, not necessarily the percentage rates. So you can see this color coded here tells you across your borough, how big your cohort is in each of the networks. If you did specifically want to check on one of them, again, you can use the nice little features here to click and just see how you're doing in, say, this particular case, it's the highway network. Just unclick that again. And again, if you want, you can change this easily enough. So it's quite nice functionality, but obviously we're very happy to hear feedback and change requests. I'll just go into the PCN business rules. So in this one, as I say, this one is related to what you're actually going to get paid for. This is the volumes you get paid for, and this information I believe will be automatically uploaded via CQRS. Probably I assume at certain points in the month, but using the dashboard you can get a viewer to see what kind of volume of activity will be uploaded. And again, you can break it down by practice and by network if you wanted to, or select on one of the other areas. Take your filters off. Take you back to the full report. Any questions on the functionality of the dashboard at this stage?
I have a few in the chat, not about the functionality.
Oh, okay.
But,
yeah, I don't want to jump ahead of Anna dealing with all of the questions. I just thought if there's anything people particularly wanted to query, to to say I don't quite understand that, or could I have a better look at how that works. If you just stick a hand up, that might be the easiest way. No? I can't see if there's any hands. I'll rely on you, Lacey.
Yes, we got Farida.
Yes. We have a question. Do we get a link for the access to the dashboard?
Sorry, you're not coming through very well there. I can't hear you quite.
Can you hear me now?
Go on, I just boosted the volume.
Is it better?
Bit better.
Okay. How do we access the dashboard?
Oh, we'll send the dashboard round to you initially. So everyone who's in this session now will get a copy of this along with the slides, and then it'll go on our website the way we normally put them on our website. If you send your feedback to myself or Anna or Lacey, we'll in terms of how the functionality works, we'll collate that and take that into account for future iterations.
Okay, thank you.
No more hands at present, Keith.
Okay, well then I think I'll push back onto Anna for the main agenda.
Thank you.
I've got another question.
Let me just stop sharing a second.
I've got another question, sorry.
Yes, Farida, go for it.
Hi, so this question is in regards to the searches.
Sorry. Can I stop you for a minute? And I'm going to finish two slides, and then we open all the questions. Okay, just hold this for a second. So I've collected all the resources for you so that you can access them really quickly. All the specifications and stuff that you need about this this scheme. You can, in terms of searches, templates, any help at all, you've got your facilitation support per locality, but you also have your management, and then you've got your management support. So if you're a clinical director or someone from the medicines management team or the CCG, you can contact the management team to discuss requirements. And now I'm going to let you all ask any question whatsoever.
No,
so
I'll
go back to Farida.
Now it's fine.
Farida, are you okay now?
Yeah, I'm fine now.
Yep, so I have a couple in the chat then for you, Anna.
Okay.
I have one from Bhavika. Are there targets as of yet?
Not that I know of, but someone in this call might know the answer. I assume that there must be a formula about how many full-time equivalent clinical pharmacists you have per network, and that would be the basis of how many SMRs you have to do this year. But I don't know the exact answer to that. I wonder if there is anyone here who does know. No? I definitely haven't seen any information for that yet.
Okay, so then I've got one from Fatima from Starlane. Is the data on the dashboard updated regularly?
We will be publishing this monthly.
Lovely. And one from Mina. You have Barking. What about Dagenham?
Sorry, Mina, that's just a labeling issue. We Barking and Dagenham come as one, as far as I know, Keith.
Yes, your network should be in there. I mean, what's the name of your network? I'll bring it back up again quickly. I can bring your practice up if you want.
You can bring my practice up and show us. It's no problem. And Network East. It's. I don't want to be left out.
East.
You know me.
There you go. This is your network. And if you just pull down on here, I can. So they are a little bit fiddly, some of these tools. What's your practice?
Churchelm Lane.
Churchelm. Okay, well,
Not done any.
you've
Done
done.
two.
No,
Thankfully.
you've done quite a few on Group C. You're doing
Yeah.
pretty well there. That's on
It's quite
meds
nice.
commonly associated with medical errors.
It's quite nice to share with everybody that you can drill down and look into your own practices, and it gives you a chance to look at the areas that you might want to focus on, and particularly those who've got care homes or an area if you've got a concern or you were wondering about. And it's a great opportunity to think about any quality improvement projects, particularly for any people who have learners in the practice. If you have any pharmacists who are learning or part of the PCN, or any trainees. So quite a nice project for anybody learning for their prescribing. So, you know, great opportunity for learning and development and quality improvement.
Thanks, Nina. Stop sharing again.
I have another one from Bavika. How much is the payment per SMR?
Again, I don't think there is a payment per SMR. I think I'm not very clear about the payment mechanism. I suppose it's about meeting the requirements. But no, I don't think there is like a price per SMR, as far as I know.
Lovely. Have one from Karishma from York Road Surgery. Our pharmacist completed SMRs and used the Y282B SMR read code on system 1, but the system does not seem to be talking to the Eclipse tool. Any advice, please?
This is a difficult one because the Eclipse tool is external to your GP clinical system. I don't think they've developed an API yet, and that's what it's called when a new piece of software can talk directly to a clinical system. So I really don't know why that would happen. I think it's something to do with the frequency you refresh the data, but you will have to get in touch with the support for the Eclipse tool, I'm afraid.
Lovely. I've got one more in the chat and then we'll go to Hans from Bushra. Is payment based on the outcome of SMR? If so, how should we record this?
I'm not sure what you mean by outcome. As I said, the whole point of this exercise is about doing as many SMRs as possible. And in terms of what NHS Digital gets, I think they just get how many SMRs you have done. They don't actually know the quality of them, unfortunately. I'm hoping that the quality will be picked up in some other way. So yeah, to say that it's been done, you just literally tick the box that says structured medication review done.
Lovely, thank you, Anna. And I've got one hand up at the moment. Mohammed?
Yeah, it was just to clarify a few things. There is no payment per se as it is, and there is no target. Targets will be set locally based on capacity, etc., and based on discussions. In terms of Eclipse, as long as the national SNOMED code is used, Eclipse SMR will pick that up now. It wasn't before, but it will pick it up now. So as long as that, and I understand that your templates have that SMR code within it, so it
yes.
would be picked up.
Oh, that's great. Thank you.
The one risk, and it's so nice to see so much data and so well-populated data, is that you could do an SMR with a very simple patient. You could do one with a really complex patient, and it could take 3 hours and you would count as one. So we just have to caveat the data with just that health warning that it doesn't genuinely reflect quality.
I really appreciate that comment. Well, your intervention was really helpful to clarify the payment mechanisms and the negotiation. And yeah, I totally agree with what you said. Some structured medication reviews are incredibly difficult, others are much easier, and just one code doesn't reflect the work you are doing.
So those people who choose Eclipse SMR in terms of identifying the highest risk patients who are on 20 odd medications and lots of dependency drugs might end up doing one for 3 hours, and somebody who has just identified somebody with one condition could end up doing it in 20 minutes.
Yeah.
So, but it's good to have data.
Brilliant, thank you. And Mina?
Yes, I just wanted to make a comment about how to view this, because although there isn't a payment, and Mohammed's right that local areas may set up a scheme to say if you've hit so many SMRs, then you might get a payment, and that's within each PCN to discuss that. Remember, you've got your ARRS funding that can help to improve the quality, and this would be an ideal kind of thing if you were employing staff in your under the ARS to do that. But some of the areas that are covered, like care homes, like learning disabilities, they attract the payment themselves, and part of the delivery of that enhanced service is to do a structured medication review. So please bear in mind that you might want to search and do the easy ones and not do the difficult ones, because they take a lot of time, but you might be shooting yourself in the foot, because if you don't do the structured medication review, say for your care homes, you may not achieve all the things you need to achieve to get that payment, or for your learning disabilities. So I would see it slightly differently, rather than, oh, well, if I do these, I'll get more money. I would see it as, here is a tool by which to have a medication review that is structured, make sure that you are providing good quality care. And it's a really good way of evidencing that, to show that you are taking care of your LD patients or your care home patients properly. And bearing in mind, if we do stop the anticholinergic burden, or do stop these, some of the Z drugs and stuff, it is a challenge, but it means that if you put that effort in, you'll get it back. You'll have less issues with patients subsequently, because they're not on those medications. You'll have less requests for medication. So although it's not a money in your pocket, sometimes those benefits are in time and in hassle, and they're not countable, except that you feel it and you feel that benefit more than you can count it. So I would see it as a tool to deliver some of the other targets that do attract a funding element, that have a funding element to it, that do attract a payment.
Brilliant, thank you, Mina. I have two more in the chat for you. One from Caroline. Can all CPs do the SMR, or do they need to be IP or be on CPPE?
Oh my goodness, I got lost with that, sorry. I thought that any clinical pharmacist could do an SMR, which is the only acronym that I can understand, but maybe Mina can help me.
Or Mohammed may be able. Oh, Rafida's got her hand up. Rafida, please say, because you know about this well.
I was going to say the clinical pharmacist needs to have training, and CPP are doing structured medication review training on CPPE. But yes, they should have gone through the pathway in the first place to be doing them.
Thank you.
And one from Shahima. I agree. What about patients that need follow-up? Often an SMR generates referrals and assessments, and then another consultation at least. It would be good to have this accounted for.
Yeah, I think we've covered this. The system is too blunt to account for all the work you have done.
And I think that is all the questions.
The search, oh yeah, I've already answered.
You answered the search.
You can find the searches in your practice support folder.
There's a hand up, Mohammed. Oh,
Just wanted to, I think there is some worry amongst everywhere. This will be like a performance management tool. I think they should just view it in the context that it is a guide. It gives some sort of idea, as Mina has pointed out so well, that it's the quality that counts as well. So I don't think everybody should get so worried about being performance managed on this. It's more like gives you an idea, shows you where you are, but at the end of the day, it's who you are targeting, and it's better to target those who benefit most from it rather than just simply getting numbers done.
That's great. Thank you, Mohammed. So yes, please, we're going to send you the dashboard. Is the first one of many other NEL dashboards that we're going to be producing. I think the next one that we're going to launch is the learning disabilities one, but there will be others coming. So please do keep bringing us feedback. And by the way, you can you will get a link to our feedback form in the email where we send you the slides and the dashboard. So please do let us know if you want something different or what will help you on your day-to-day job. And that's it. Thank you very much.
Thank you.
Bye.
Thank you.
Thank you.